This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
On your seats you'll find just a little postcard with some information about advanced care planning in Victoria, the state of Victoria, promulgated by the Department of Health and Human Services, or the Department of Health. And that's got a link to it which has lots of useful information you may find of interest. This morning we're talking about acute end-of-life care in hospitalised patients, and I've chosen that topic very specifically because this is not talking about chronic palliative care, as I'm going to allude to in my brief slides. Can we get those next slides up, please? Thank you. So this is a very deliberate topic heading, and we've got 4 experts. I'm going to speak very briefly. I'm not speaking for 15 minutes. I'm just going to introduce the topic. I just want to talk very briefly about the phases of end-of-life care, particularly the chronic trajectory that we see, the overview of deteriorating patients, the rapid response team in end-of-life care, and then I'm going to introduce and prelude to the remainder of the session. So this is a diagram that I developed with Jennifer Hill, who's one of our speakers, which looks at a stereotypic trajectory of a patient who encounters healthcare providers at about 1 year of life when they're diagnosed with a condition which may be life-limiting. And they might get hospitalised, but they'll return to relatively independent function. 1 month or months out, the patient is becoming increasingly frail, and when they're admitted to hospital, it may be recurrent, and they may actually be at risk of dying during that hospital admission. But in the last week of their life is the hospitalisation, which is the central admission when they're associated with death. And very crudely, you can think about the 3 types of encounter where end-of-life care planning and advanced care planning can occur in these different modalities. So there's advanced care planning, which hopefully occurs 1 year to 1 month. Palliative care services, which occur in the months. But increasingly we're seeing the rapid response team being involved in the last week of someone's life. So when someone deteriorates, they simply develop abnormal vital signs or a decline in their clinical status. And that deterioration can be reversible, in which case we want to avoid morbidity and mortality, or it can be irreversible, in which case the major function should be good symptom control and what I call spiritual, and I don't mean that in the religious sense, and maintaining dignity and having a good death. In the first group, you want early intervention and aggressive therapy to prevent the avoidable morbidity and mortality. But in the second group, ideally you want to recognise early that the patient's dying and avoid therapies that I call non-beneficial. And I always try to avoid the word futile because it has a lot of emotive overlay. I talk very much about non-beneficial care. But in both cases, the patient needs to have the right care in the right place at the right time. And this is the challenge. So the original aim of rapid response systems was to prevent cardiac arrest and adverse events, but increasingly we're seeing it's providing end-of-life care in hospitalised patients. And there was a systematic review done by a trainee, Lee Tan, and Anthony Delaney. Lee Tan spoke about this last year. End-of-life care discussions are one of, if not the most common intervention that occur during rapid response team encounters. And perhaps when you look at the criteria, and these are the Austin ones, you may see why. Obstructed airway, nausea, breathing or stridor, problems with breathing and hypoxemia, low blood pressure and low urine output, and altered conscious state, reduced conscious state. You can see when you look at these and think with an open mind that sometimes it might be difficult to distinguish deterioration from dying. And so that's all I'm going to talk about. The remainder of the session we're going to have 4 experts. Jennifer Hills from the Australian Commission on Safety, Quality and Healthcare, and she's going to talk about the way that we've developed centralised government promulgation of material relating to this topic in Australia, and particularly around policy development. Karen Dettering is the lead coordinator of advanced care planning for the state of Victoria, and she's going to talk about the importance of advanced care planning. She's also one of the co-authors of a paper, the only randomised control trial I'm aware of that shows advanced care planning improves patient and carer outcomes. And Julie Moran, who's a Director of Palliative Care Services, is going to talk about alternatives to the rapid response team for end-of-life care planning. And finally, Ken Hillman is going to talk about what research we need to do in this area.